Thank you for the kind introduction. Good afternoon. First and foremost, I would like to thank you, the Korean Society and Anesthesiologists, for inviting me to share with you some of the thoughts that I have with regards to point of care ultrasound for regional anesthesiologists. Specifically, I would like to thank Prof. Taeyop Kim for inviting me personally. Okay, let's start the ball rolling. I've shared this topic on various platforms, maybe not exactly, but somewhat similar topics. This was a point of care, perioperative point of care ultrasound talk I've given sometime last year in the Australian New Zealand College of Anesthesiologists meeting held in Kuala Lumpur. I have nothing or no conflict of interest to disclose. This is the current hospital where I'm working in. It's a 200-odd bedded private tertiary hospital, and this is what this is what I have been using for the past few years, the BK system. And you could see this is an example of somewhat my assistance to the surgeon. What I'm scanning is actually a sample, or say an excised breast tumor, where the surgeon have requested me to see whether I've actually, or he has actually managed to excise the whole tumor. And this is the current system that I'm working with. This is the export sonocyte system. In terms of affiliation, I was the past convener for the special interest group in regional anesthesia under the College of Anesthesiologists, Academy of Medicine, Malaysia. I've also been the past president for the Malaysian chapter for WIN-FOCUS, which stands for World Interactive Network Focus on Critical Ultrasound, which is a non-profit scientific body involved in the propagation of point-of-care ultrasound. Okay, in order for us to talk on the present and the future, let's just visit what's been in the past. With regards to the first documented use of ultrasound in regional anesthesia, since this is a regional anesthesia track, this was the first documented use where the ultrasound, Doppler ultrasound specifically, was used to locate the supraclavicular artery, and this was done to assist the location of the brachial plexus. This was actually a Singapore publication way back in 1989, where the two authors documented before and after images of the brachial plexus in the axillary component. And with regards to the actual ultrasound-guided regional anesthesia, Stephen Capral and his Austrian group in 1994 documented this, a supraclavicular approach before and after, and you could see that the images way back then, 20-odd years ago, was more imagining rather than imaging, because it was probably not of good quality. And now we have good ultrasound systems, which we can actually see not just the macroscopic, but to a certain degree some microscopic structures. For example, looking at the subperitoneal compartment, epineurium, paraneural sheath, and so on and so forth in this particular section of the sciatic nerve. We also have, I won't go into great detail as the first speaker has alluded to this, ultrasound guided central neuraxial. Also, we have documentation of the use of ultrasound in thoracic epidural. Now, interfacial plane blocks has become very popular, from transversus abdominis plane block, portus lumborum, the PAX block, PAX 1, PAX 2, serratus anterior, and the new kid on the block will be the erector spinal plane block, and it's been shown to be quite efficacious, for example, in open cardiac surgery. I won't go into great detail, but this is just to share some of the interesting concepts and images of the ESP. Okay. With regards to ultrasound-guided cannulation, this was the first documented use by this Japanese author on the use of ultrasound guidance in the IJV cannulation, and now it has become standard. This was the first documentation in 1918 Lancet on the use of actually transesophageal echo, and now transesophageal echo is a standard tool in cardiac anesthesia. And not only that, it has also encroached on non-cardiac surgery, and this particular review article, documenting the use of TEE in intraoperative hemodynamically unstable non-cardiac patients. Okay, a bit of introduction on where point-of-care ultrasound in the perioperative period started. This was actually a first documentation way back in 2011 in anesthesiology, where 2 cases of intraoperative pneumothorax was diagnosed with lung ultrasound. And in the same issue, there was an editorial. If I could read out a paragraph of it. If transesophageal echo, vascular access, regional anesthesia represent established mainstream applications of perioperative ultrasound, chest ultrasound, and other modalities have emerged more recently among anesthesiologists. So you could see this was the beginning of point-of-care ultrasound. Apart from the established TE line access, or say ultrasound guided line cannulation, as well as regional anesthesia. In the same year, New England Journal of Medicine published this review article. If I could use the definition here for point-of-care ultrasound. Point-of-care ultrasound is defined as ultrasonography brought to the patient and performed by the provider in real time. Point-of-care ultrasound images can be obtained nearly immediately, and the clinician can use real-time dynamic images, allowing findings to be directly correlated with the patient's presenting signs and symptoms. If I could kind of simplify this, so point-of-care ultrasound is ultrasound performed by the clinician, not by the diagnostician, namely radiologists or radiographers. It is performed at the bedside. So bedside can be dynamic, as far as we are concerned, it can be, from the emergency department, the operating theater to the ICU. And as well, another point is that it's focus. We are not here when we are to perform a full ultrasound examination. We are here just to perform some focus aspects of the ultrasound examination. And the list in that particular New England Journal publication is quite lengthy, but if you look at under anesthesia, the guidance for vascular access, regional anesthesia, intraoperative monitoring of fluid status, and cardiac function. So it's still the 3 main established mainstream back then was quoted in the list. In 2017, a series of point-of-care application was published in RAPM. This was the editorial for that, and you could see that in 2017 and 2018, focus cardiac ultrasound, lung ultrasound, and gastric ultrasound was published as part of the series. Later on, 2019 and 2020, there was FAST, which stands for Focus Assessment with Sonography and Trauma, and the point-of-care ultrasound for the pediatric population. Okay, where do I want to take this? And if seeing the list of lectures, there have been other speakers who are also covering it. So I would, as I point out in my learning objective, would just like to do an introduction. It's not too technical, because to be too technical in 25 minutes, it would be impossible. And I would kind of skim through the literature, so that mainly my main objective is just to create interest. One of the first, I would say, complete description of the point-of-care ultrasound is by Luca Neri et al., where he described the ABCD primary assessment. I won't go into great detail, but this is the airway, breathing, circulation, right up to disability and exposure, using ultrasound, point-of-care ultrasound to complement the ABCDE. And recently, this group, American group, also described the perioperative point-of-care ultrasound, and they used the acronym FORESIGHT, which is Focused Perioperative Risk Evaluation Sonography, involving gastroabdominal, hemodynamic, and transthoracic ultrasound. Okay, let's move to airway. This is, I took this picture while I was assisting my ENT surgeon who was having difficulty in locating the airway. So I'm just pointing out to him where the thyroid cartilage is. And this is quite recent, where this Italian group published a concept sort of using how they use ultrasound, or how they propose that ultrasound is being used as part of an airway regional anesthesia strategy. I'm going to kind of zoom in. So if you have a difficult airway, and and where airway is indicated, you need to look at the patient perspective, surgery and surgeon, and if in fact you think that there may be a difficult airway, and this is where you strategize and you include ultrasound. If I could point out here, ultrasound cricothyroidotomy membrane identification as a plan A or plan B in the event that the standard airway management failed. And eventually you move down if there's a need, or if the decision to proceed with regional anesthesia is confirmed. With regards to the literature over the last 10-15 years has been quite, I would say, quite busy with airway literature, airway ultrasound literature. I would just like to recommend this particular one by my Malaysian colleagues, Focus Airway Ultrasound and Armamentarium in Future Airway Management. It summarizes the literature with regards to the available evidence, but as well, not just the management, but also to use ultrasound in predicting difficult airway. I'm just going to quote this particular review article in the Canadian Journal. So, as mentioned earlier in the algorithm, the management to identify the cricothyroid membrane, trachea, as well as you could actually confirm tracheal placement we're using ultrasound. I'm just going to kind of show you a short video, and this is where an endotracheal intubation took place, and this is on the right side is where the esophageal intubation took place, and you could see that there's actually a movement of the thyroid gland, suggesting that the esophageal is being intubated. I won't go into great detail, but this is where you can actually identify the cricothyroid membrane, and these are just documentation of the use of a real-time needle guidance for cricothyroidotomy. As mentioned earlier, this was a 2018 RAPM publication on the use of gastric ultrasound. So if I can kind of quote this, that although gastric ultrasound is a relatively new point of care application in the pre-op setting, its relevance for the regional anesthesiologists and pain specialists is significant, as our clinical practice often involves providing deep sedation without a secured airway. Given that pulmonary aspiration is a well-known cause for peri-op morbidity and mortality, the ability to evaluate NEAL per os status and risk stratify patients scheduled for anesthesia is a powerful skill set. I'm just going to use the review article in BJA in 2014 just to illustrate on the use of. So technically, what you are trying to confirm whether the antrum is, for example, here filled with fluid, or in the worst case scenario where it's filled with solid, and this is where you want to risk stratify and decide how deep a sedation, or whether sedation is something that you are going to consider, and also of course in your airway management. Okay, lung ultrasound. The review article in 2017 in RPM, and if I can zoom in, as anesthesiologists routinely perform nerve blocks that put patients in potential risk of complications such as pneumothorax or diaphragmatic paresis, it is important to understand how to use lung ultrasound to evaluate for these conditions, as well as to differentiate between other potentials causes of respiratory distress such as interstitial syndrome and pleural effusion. Okay, so the article gives you an idea on where to put the probe. I won't go into great detail, as I promised that it's not going to be very technical, but This is an example of how you put the probe to look at diaphragmatic paresis. Okay, and you could, this is the liver, something important for you to diagnose or differentiate because there may be consolidation. Can you see this is hyperechoic line? This refers to the diaphragm, and when this is moving, definitely there is no diaphragmatic paresis. With regards to pneumothorax, this is Valpolichelli publication in the International Evidence-Based Recommendations for Point-of-Care Lung Ultrasound. This is considered the main reference in the literature for lung ultrasound. I'm just going to put up this slide. So you can see this part is sliding. So this is what we call sliding side, and this is non-sliding. So basically, when the probe is put somewhere here, this is what you get. So a part of it is non-sliding, and this is sliding, and this is what we call lung point. So lung point, when you have lung point, 100%, it is a pneumothorax. Just to highlight, because in the REPM review mentioned about interstitial syndrome, I'm just going to quote this article. So this is what you see in interstitial syndrome, where this is what we call comet tail artifacts, or I would say B-lines. Okay, and this corresponds to a wet lung. The Blue Protocol, published by Liechtenstein, the father of lung ultrasound. I won't go into great detail, but just highlighting, since we are still facing COVID as a pandemic, there have been numerous articles documenting the use of lung ultrasound in detecting and managing COVID pneumonia. Okay, focus cardiac ultrasound. I'm just going to zoom in into some a paragraph. However, given that ultrasound-guided regional anesthesia is emerging as a standard of care, there is expanding role for ultrasound in the perioperative setting for regional anesthetists to help improve patient assessment and management. So providing valuable insight into cardiac physiology, focus can also be used either to assess patient at risk of complications related to regional anesthesia or to improve management of patients undergoing regional anesthesia care. This is a 2014 publication in JACE by Gabriel Villa. It is an important also reference for focused cardiac ultrasound. And with regards to when I mention focused cardiac ultrasound, we are actually concentrating on this, the one at the bottom of the pyramid, because doing the top bit will be the experts, and then you have the proper echocardiographer, and then there's a level 1 or intermediate echocardiography, particularly in the use of ICU. This is very basic, and this is what we're aiming for. And when we talk about basic, we are concentrating on some of the pathologies. If you look at the slides, they are the severe LV dysfunction, hypovolemia, where you have small hypercontractile heart chambers, the tamponade physiology here, and as well as a massive PE, which is right ventricular strain. There have also been documentation on focused TEE, particularly by the emergency physicians in the resuscitative period. The use of IVC scan is also important to predict hypotension. Of course, this particular study is for patients undergoing GA, but you can use it to actually predict the risk of hypotension after spinal anesthesia. I won't go into great detail, but in short, when the IVC is more collapsible in a spontaneous breathing patients, then the patient is actually more hypovolemic and at risk of hypertension. Okay, let's follow protocol. With regards to protocol, the focus assessment with sonography and trauma is actually the first protocol being described for POCUS in the emergency setting, but this is a 2019 REPM publication. There's a list of indications, quite interestingly. I think I use it whenever I have definitely hypotension in the post-anesthesia care unit, or even before in the pre-op setting. And I use it particularly and also in re-evaluation of trauma patients. Won't go into great detail again, but the standard 4 views and in the standard fast, we include the lung ultrasound as well. But what we are going to interested to see is actually this, which is you can see this is normal, the Morrison's pouch, and you can see there's a sliver of hypoechoic space here, which signifies that's a possible fluid, and in trauma, it's blood until proven otherwise. Okay, and with regards to incorporating all this, when you evaluate a shock or severe hypotensive patient, you can actually use it to, I'm just quoting a protocol named RUSH. So you evaluate the pump, which is the heart, using focus echo. Then you evaluate the tank, looking at sequestration of fluid. For example, looking at the fast, whether there's any blood or fluid in the peritoneum, and also looking at lung views, whether there's any effusion, and eventually looking at the pipes, for looking at whether there's any leakage from the main big arteries, as well as looking at DVT for a possible cause of a pulmonary embolism. I won't go into great detail. Okay, but there are also incidental findings that you ought to pick up if you're doing ultrasound guided regional anesthesia. This is a case report of deep vein thrombosis femoral nerve. While doing a femoral nerve block, I had experienced this myself. I'm just going to show this compression sonography, where this is actually a thrombus within the vein, and you could see that it's not incompressible at this point. The other pathologies that I think we should be able to pick up, of course, I use this sometimes to assist my surgeons when they're having difficulty. For example, this is looking at foreign body, looking at abnormal nerves. This is quite important when you're doing your brachial plexus block, for example, interscalene. You will also you may be able to pick up abnormalities of the thyroid gland, and there may be a need to refer to the appropriate specialty. And also, of course, looking at abscesses. This is also important, particularly when you're dealing with, when you're doing blocks and you're doing even peripheral cannulation, and looking at not just abscess in this matter, but also looking at edema. So this will tell you whether the IV cannula is actually inside too. Okay, where are we? I'm left for about 4 minutes. I'm just going to skim through. Where are we in the future? We have seen more advanced machines and more, I would say, miniaturization of the systems. There have been also, this is a circulation 2017. You could see the various models where it's handheld and very mobile. This is a GE, and this is the butterfly system. And you have also the systems without any cable and connects to your smartphone or your tablet. This is the Clarius. There have been articles to demonstrate this is titled The Democratization of Ultrasound. And also in JAMA 2018, there's a special communication article, time to add a fifth pillar to bedside physical examination instead of the 4: inspection, palpation, percussion, auscultation, and now the authors recommend that we should insonate as well. So, apart from auscultation, we should extend our physical examination to include insonation. New York Times published this sometime in April last year, where this NGO, this charity group, used ultrasound to pick up chronic pneumonia, chronic TB in areas where X-ray is unavailable. Then also studies, this was by Save the Children, and the last I checked, they haven't published this, where they did the study to use ultrasound in detecting pediatric pneumonia, where they're in resource-limited environment, where in Africa, where there's chest X-ray is not widely available. I think it's high time for us to embrace. We understand that point-of-care ultrasound is the future, or I should say the present. This was written 2017, a North American perspective, and this was also an article to suggest the curriculum on how to teach perioperative ultrasound to anesthesia trainees. We have now artificial intelligence, and we grew up watching Terminator and Matrix, but just to highlight some of the models, this is actually a VSonic system where they could actually detect where the nerves are based on using artificial intelligence. I won't go into great detail. This is a GE model where they can do auto VTI, volume time integral, auto IVC, inferior vena cava, and calculate it for the user. There have been also systems like this Oculus, where you can put your probe on the bladder, for example, and it immediately calculates the bladder volume. Where are we heading in terms of training? the standard training would be workshops, and we've used to this, but now COVID-19 has changed everything, and we are now back to new in the new normal, and hence why this conference is a virtual conference. I've used this. This was actually a picture taken in my previous hospital in Singapore, where we used the HeartWorks to actually train our doctors. We won't go into great detail, but there are also systems. For example, this is actually a virtual system where you hook up to the Sonosim web page, and with this particular gadget, you can actually simulate an echo an echo model. So the perioperative ultrasound, the future is now, and I can kind of quote the stethoscope. It is now the stethoscope of the future. And with that, I thank you. I'm left with about 30 seconds. Thank you very much.